Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friend. Welcome back to this week's episode of the Healing Pain Podcast. This week, we're discussing the impact of breathing on chronic pain and relaxation. Joining me this week for our expert guest and interview is Dr. Ali Gholamrezaei. Dr. Gholamrezaei originally trained and worked as a general physician and eventually became interested in the mind-body connection and started clinical research, which involved looking at cognitive behavioral therapy, stress management, and hypnotherapy for gastrointestinal conditions such as irritable bowel syndrome. He eventually pursued and completed a PhD where he conducted experiments on slow, deep breathing and how it impacted chronic pain. He is currently a research fellow at the Pain Management Research Institute at the University of Sydney in Australia, where he's working on the development of a digital behavioral intervention for chronic pain management. On today's episode, we'll discuss techniques being used for slow, deep breathing. What are the psychological as well as physiological effects of slow, deep breathing, and the evidence supporting slow, deep breathing to attenuate chronic pain. I want to thank you again for joining us this week on the podcast. Again, if you enjoy this episode or maybe a past episode that you've listened to, head on over to iTunes and give us a 5-star review and say something nice. And make sure to tag me on Instagram. My Instagram handle is at Dr. Joe Tatta. Okay, without further ado, let's begin and let's learn about slow, deep breathing and pain with Dr. Ali Gholamrezaei. Hi there, Ali. Thanks for joining me for this week's episode of the Healing Pain Podcast. It's great to have you here.
Hi, Joe. I'm glad to be here.
Welcome. I know you're in Australia and it's a bit early, so we welcome you and wish you a good morning. And people who are following along with the title of our podcast probably noticed there's a MD and a PhD after your name. So you have lots of years into medicine and health. I know early in your career, you started kind of as a general internist or general medicine. And now a lot of your research focuses on the brain and the mind-body connection, which is something we love talking about on this podcast. How did you transition from that kind of more of a general medicine, internal medicine perspective to now a strong focus on kind of mind-body medicine and investigating that?
Yeah, so I was trained as a medical practitioner. So my interest into mind-body medicine and complementary medicine started since the beginning of my medical training. I saw a flyer around about a hypnotherapy workshop. It was in 2002. And I thought, that looks interesting. So I went to that workshop, and that was the beginning of my journey in mind-body medicine and brain-body connection and research interest. So I went to that workshop and I saw people talking about clinical applications of hypnosis in medicine, particularly. And I thought, okay, that's interesting. So I started learning what is hypnosis, what is hypnotherapy. And we had this research group. We initiated a research group mainly composed of medical students. We had some senior students who supervised us. And then we read about hypnotherapy and research around hypnotherapy. And then we started practicing it under supervision in our clinical courses. And then my focus was shifted to more research part of it rather than just the clinical practice of it. And then one research after another, and then I get into mental health, physical health, the importance of mental health in physical health, which is sometimes missed in clinical field. So
And today I know a lot of your work focuses on breathing. which is
Yeah.
really just distilled down to a very specific topic, right?
Yes. So I did a bit of research on like how mind-body practice can be used in various medical conditions, like hypnotherapy. And in hypnotherapy, breathing is used in many complementary and mind-body therapies, like hypnotherapy as a component. So for after I graduated in medicine and I did a bit of clinical practice, I was looking for a research group who is working in this field particularly. So I searched and I found a very good group at the University of Leuven in Belgium. So I applied for a PhD position there. The research project was about the influence of slow deep breathing on pain. So that was matched exactly with my interest. And so I moved to Belgium and I started doing research on breathing. And it was mainly experimental approach to breathing, its psychophysiological effects, and whether it can influence pain and how.
Your current research focuses on the impact of slow, deep breathing on the ability to reduce or impact pain. What is slow, deep breathing?
I think a good point to start is to define what is a breathing exercise, because a slow deep breathing is a breathing exercise, and the National Center for Complementary and Integrative Medicine gives a very good definition of what is a breathing exercise. So a breathing exercise is any change in breathing behavior. It can be a change in breathing frequency or rate of the breathing. It can be a change in breathing depth, how much air we take in and out. It can be a change in the airway that we use for breathing, like breathing through the nose or through the mouth, or a combination of that. And any other behavior that can accompany breathing behavior, like, for example, diaphragmatic breathing, or any of these combinations can generate lots of types of breathing exercises. And the slow deep breathing is perhaps the most common type of breathing exercise that is being practiced by people for various physical, mental health conditions, not only disease or disorders, but also to promote health and achieve mental states. I think that's and about what happens during slow deep breathing, why we call it a slow and deep breathing. So what happens during slow deep breathing is that the breathing rate is reduced, and at the same time, the breathing depth is increased. Some people call this slow breathing, some people call it deep breathing, some people call it resonant frequency breathing. I prefer to use the slow and deep breathing term because it's very kind of operational definition. And it usually happens together, because when we reduce our breathing rate, we have to increase our breathing depth so we have the same amount of ventilation and gas exchange, so we don't hyperventilate or hypoventilate. So in summary, breathing, slow deep breathing is a breathing exercise during which we breathe more slowly and compared to the normal breathing rate, and more deeply.
So slower and deeper.
Slower and deeper. But there are many techniques to do that, which we can discuss it.
Yeah, let's talk about some techniques, because we're a technique-friendly podcast. We love to share some simple things that people could do, potentially if they're home right now, maybe in a safe or quiet space, and they might be able to follow along with you.
Yes, definitely in a safe and quiet space. So yeah, there are different techniques. I don't know how many techniques are available, but there are perhaps many, because you can imagine you can combine many components that I talked first, like the way that we breathe through, the rate of the breathing, the depth of the breathing, the ratio between the inspiration and expiration. So there are postures of the body. So there are different techniques used for slow and deep breathing. Some of them are more common or more commonly mentioned in the literature, I can say. Like, for example, we have this pursed lip breathing, which is breathing through the nose and breathing out through the mouth while pursing the lips like, so that's called pursed lip breathing. Or you can simply narrow your mouth so you can better control the breathing out phase. That's a common technique that is used for pulmonary rehabilitation, like COPD. And there are some reasons behind that, like the intrathoracic pressure that is generated before the breathing out or expiration. And that's also commonly being used in research when we want to investigate the psychophysiological effects of slow deep breathing, or at least our laboratory use it mainly. The other common technique is unilateral nostril breathing or alternate nostril breathing. That's a very common eugic breathing, and it's breathing through one nostril, closing the other, and either breathing out through the same nostril or changing. And sometimes there is this famous posture for hand. So that's also a common breathing exercise being used. And there are some theories and hypotheses that breathing through one nostril activates unilateral or ipsilateral part of the brain, but not that much of evidence there. But that's why we breathe through one nostril or the other. One reason. And also, there are some modern techniques of slow deep breathing, like, for example, and recently some researchers used inspiratory muscle training devices combined with the slow deep breathing, and they found that it optimized the effect of a slow deep breathing on cardiovascular parameters, and they use it for hypertension, which is somehow similar to some maneuvers that we do during slow deep breathing. Like during ujjayi breathing, we close the glottis to create that pressure, or during unilateral nostril breathing, we try to mimic that. Well, that's not the main reason, but that's kind of same thing happened during unilateral nostril breathing. Or HRV biofeedback, I can say, is a modern technique for doing slow deep breathing. There are other components to that as well, of course, but that's also using devices and biofeedback to monitor your breathing and monitor the final outcome of the breathing effect on cardiovascular system, that is the heart rate. So you try to follow your heart rate variability and increase it as much as possible. That may end up you breathing at a certain breathing frequency through the time. So there are also modern techniques for slow deep breathing, diaphragmatic breathing. So there are many, many techniques. And what is the difference between them? Well, we need to investigate. And that was one research that I did. And there are some differences in terms of psychological and physiological effects. And we didn't investigate that, but I can imagine the clinical applications can also be different.
Yeah, and that investigation you looked in was around how slow deep breathing can impact pain, or how it may modulate the pain experience of a certain group of people.
Yeah, so we wanted to know whether our main focus was what is the mechanism of a slow deep breathing on pain. So we tried to increase the autonomic modulation as much as possible in a comfortable way, of course. So we try to find a method that is that can generate the highest modulation in autonomic activity, and that was actually using the inspiratory load during slow deep breathing that optimized that the effect of a slow deep breathing on baroreflex and subsequent cardiovascular response. And we used that and compared it to pursed lip breathing, which in another study, my colleague found it effective in reducing pain. So we tried to compare them and see if it can further reduce pain and how. And we also So in one of my studies, I compared pursed breathing with loaded breathing and unilateral nostril breathing, left and right, because there were some studies, inconsistent though, that one may activate, or well, let's say it's more carefully, one may modulate cardiac vagal activity more than the other, which was not the case in our experiment at least. So and it was less influential on cardiovascular parameters than the pursed breathing. And the reason was very interesting. But anyway, we dropped that one and we compared the other two in a subsequent experiment on pain.
Right. And the subjects in your investigation, this is experimental pain. These are not people with, let's say, fibromyalgia or CRPS, for example. So you're initiating pain during the experiment.
Yes. So in all of my studies in Belgium, we used experimental models of pain, and my focus was on visceral pain because of my background of research in gastrointestinal disorders. So that's looks a bit invasive, but that's the most easy access to the viscera. So I inserted a very tiny nasal catheter through the nose. I sent it to the esophagus and I delivered electrical stimulation there to generate pain. I tried it on myself a lot of time to ensure that it is painful. And see how my participant will feel. And then all participants performed different types of breathing, and they received short painful stimulation in random times. And then we also monitored lots of cardiovascular respiratory parameters to investigate the mechanisms. So we mainly focus on experimental model of pain. That is a limitation of not being able to generalize what we find in experimental studies necessarily to clinic, but also it brings some opportunities to precisely investigate mechanisms in the lab. But of course, we need to replicate findings in the clinical field.
I'm just wondering, in that study, why was the electrical shock applied to the esophagus versus, let's say, to a hand or a foot or a different area on the body?
Yeah, well, that's a good question. So I did one study and applied electrical stimulation on hand as a somatic model of pain. And I had two other colleagues, Hassan Jafari, who is now in King's College London, and Imke Kochtova. So my colleagues focused on somatic pain. I focused on visceral pain. So we had a very nice group that we always work together. So we try to have our focus on different types of, and actually Imke Kochtova used different models of pain, like heat pain, pressure pain, and electrical stimulation for pain. And Hassan used electrical stimulation for pain and heat pain. So we had a combination of different models of pain. And our results were more or less consistent, which I will get into it.
So I know you're looking at mechanisms of relief or pain relief for that, both psychological and physiological mechanisms. There are quite a number of mechanisms that you looked at and tested in that paper. Can you walk us through some of those so we see the full breadth of that?
Yeah. So, of course, we not only looked at the mechanisms or what happens in what are the psychophysiological response to slow deep breathing during pain, but also just in normal, like what happens when we do a slow deep breathing in the laboratory. So I think it's good to distinguish between the short-term effects and the long-term effects because they are different. What we see is that, and that's very consistent among different research by different groups, is that in short term, like about 5 or 10 or 15 minutes when we do a slow deep breathing, we have some typical cardiovascular responses. That's very consistent among inter-individual and inter-individually. And what we see is a typical increase in heart rate variability at the frequency of breathing. Like, for example, if the breathing frequency is 10 breaths per minute or 6 breaths per minute, we see a peak in heart rate variability at that specific frequency. And the mechanism is complex. It's a combination of central and peripheral mechanisms and reflexes and feedbacks. Usually we don't see a change or a very minimal change in average heart rate and average blood pressure in that short period. Sometimes we even see a small increase, because that slow deep breathing, especially for those who are novices and have no experience, and they are trying to follow a breathing guide, that's a bit of cognitive task, I would say. So that may increase arousal and increase heart rate, but just 1 or 2 beats on average, so that not that much. And in the laboratory, for short-term practice, we usually don't see that much of a change in affective state, but that's very much contextual. Like, for example, if you give a person a stress task, or if they are anticipating a painful stimulation, in the short term, slow deep breathing can reduce their anticipatory arousal, can reduce their arousal or stress or anxiety. But if you don't give them any task or any relaxation instruction or other mental tasks like mindfulness or things like this, usually we don't see a change in affective state. But long-term effects is a bit more complex, and that's a bit inconsistent across the studies, mainly due to having other components to the slow deep breathing, like relaxation or lots of instructions. In long term, there are some evidence that long-term practice of a slow deep breathing can reduce heart rate and blood pressure, especially in those with earlier stage of hypertension, and can reduce anxiety and stress in clinical population, but also in general population when they face a stressful situation. But most studies usually have other components like instructions, relaxation, and that's part of the difficulty investigating the mechanism. Is it a combination of them, or is it purely slow deep breathing? And when we bring it to the lab, sometimes we see it's different.
Yeah, because I know there are some studies that demonstrate deep breathing has an impact on emotional regulation.
Yes, well,
which could have an impact on pain.
Yes. Well, we investigated emotional and autonomic. We measured some emotional and autonomic parameters, trying to investigate if they are involved. In our studies, we found some effects of a slow deep breathing on, for example, anticipatory arousal, but that didn't statistically mediate the effects on pain. Well, statistically, it's not the best way, but that what we could do. So we didn't see that much of a strong relationship there, nor for autonomic systems. So we think that in our studies, at least in the laboratory, in short term, the main mechanism is distraction plus some expectancy. And I think that's also one reason there is inconsistency between some studies, because expectancy is not something that is well controlled in many studies. In one of my studies, I use a cover story. So people didn't know what is the study about. And we found no difference between controlled breathing at a normal breathing frequency and a slow frequency. So, and both of them lower than doing nothing. So that's mostly distraction, I would say, which can bring some emotional effect as well, because when you are distracted from pain, you may have reduced arousal as well.
Yeah. What stood out to me when I read your study is that there wasn't really, as you mentioned, a strong relationship with arousal or decreasing arousal, which a lot of people would tell you breathing exercises or deep breathing exercises help regulate arousal in people with many, in people in general, but your study didn't really point in that direction too much.
Yeah. So look, it's important to see how we do the study in the lab. So for example, in one study, the duration of each trial was just 1 minute, and that may not be enough to reduce arousal. In another study, the duration of breathing before the participants received the pain was 1 minute, and we found a reduced arousal in that period when we measured it. It's also important when we measure the arousal, and when we want to measure the arousal, the person has to stop doing the breathing and rate it on the monitor. So there's a bit of like manipulation there that is not what actually happens, because when you do a slow deep breathing, you close your eyes, you try to focus, and then imagine that you're doing that and suddenly someone asks you, okay, rate something. So there's a bit of manipulation there. So it's not exactly what it's not the optimal thing that we can experience in real life, I can say. So we have a reduction in the responses. So that's why we sometimes see a tiny difference, not what actually can happen in real life. But we see a decrease in anticipatory arousal, and that's also consistently shown by other studies, that when you do it. And that's I think something good to mention, that maybe instead of trying to focus on just one parameter of pain experience, that is pain intensity, we should talk about the whole pain experience, how pain experience can be transformed through breathing. It's not just the intensity of pain. We know that pain has lots of other qualities, like or how pain interferes with our function, and how doing slow deep breathing can reduce that interference, because that's part of that's an important outcome to achieve, not just the intensity of pain, but also how it interferes with our function. And that's, I think, for answering that, we need to go to clinical field and see how it can help patients.
You also track pain catastrophizing, which has been looked at a lot with regard to pain intensity. What did your study find with pain catastrophizing?
Yeah, I'm happy to ask that question. So I think one very interesting finding in one of my experiments, and that's different with other distraction techniques, was that I found that those who had higher scores in the pain catastrophizing scale, and pain catastrophizing scale is a scale that try to capture concerns about pain. So people who have more concerns about pain, or rated that way, they benefit more from doing slow deep breathing, and also controlled breathing in overall controlled breathing. So they have more reduction in pain while they are doing controlled breathing at slow or normal frequency compared to doing nothing. So that kind of suggests that when they are not doing slow deep breathing, they are thinking about pain, they are concerning about pain, and that they are focusing on their pain. They are not distracted from pain, and that may increase their pain. But when they are focusing on their breathing and their all of that sensations during slow deep breathing, their pain reduces. But that is not what we see with other distraction techniques. And that shows that, I think, when it comes to pain concerns, that the technique that we use for distraction does matter. So maybe slow deep breathing can be a technique that can capture attention well, because it is pleasant, it is relevant, it can bring some expectations, and it can bring some emotional responses as well, compared to a visual distraction, which is not necessarily emotionally helpful or seems relevant to a patient or someone who is doing a painful procedure, for example. So I think that's something very interesting and potentially clinically useful.
Interesting. So if we use, let's say, I don't know, a red dot moving on a wall as a form of distraction, and compare it to someone focusing on their own breathing as a form of distraction, it looks like slow, attenuated, deep breathing will help decrease the pain catastrophizing.
Yeah, I think
To me, there's a
yeah.
sense of one is an external distraction, the other's more internal inside us, which might speak a little bit to interoceptive processing, which is an important part of pain and some of the parts of the brain that it goes through.
Yeah, well, in our studies, we use this visual guide. So the participants need to follow the visual guide, although after a while, it's very rhythmic, so they really don't have to look at it. But we always have this visual stimuli on the monitor. Whether that has some effects, we don't know. We need to purely compare it with a visual guide, following, not following thing. But I think there are lots of sensations when you do practice slow deep breathing, lots of interoceptive, conscious and unconscious sensations, because many interoceptives signaling you don't consciously feel, but in some of them you feel if you pay attention. So you can use, and also there are evidence consistently showing that the attention task, how much it shifts your attention from the painful stimulation to that sensation does matter. So it's important that you use a very engaging task. And I think slow deep breathing is engaging. It is also emotionally meaningful and relevant. So all of these parameters help to make it very engaging, and that's make it a potentially useful distraction. But it has also other effects. Huh?
I'm just wondering, in the instruction that you provide to people for the slow deep breathing, or even the sustained breathing that you use, does the instruction have an influence on what the person might experience, even on an emotional level? Because if I said to someone, breathe in for 3 seconds and breathe out for 3 seconds, versus take a nice, slow, relaxing breath in for 3 seconds and a cleansing breath out for 3 seconds, there's a different form of expectancy there potentially that happens with each of those instructions.
Exactly. So we, in hypnosis, we say, with each deep breath, your trance state deepen. With each deep breath, you become more relaxed. So I think instruction, it's critical. Without instruction, what we investigated in the lab was purely reducing breathing rate, maybe a bit of focus attention, because we say just focus on your breathing, but just a simple sentence to help them to not distract with other instruments, things hanging from the wall, lots of things in the laboratory. So we didn't have any relaxation instruction. So that's interesting. So while we don't have any relaxation instruction, why we still see that reduced in arousal, and that can be partially because they are distracted from pain, and that can also reduce the arousal. Not necessarily distraction, that can also be due to some central mechanism. There is this recent cool study in a mouse model of slow deep breathing published in Science, that they found when they ablate some neurons in the respiratory center, the mouse becomes more calm. And they found that, that's true connection between the respiratory center and some nuclei in the brain responsible for motion and arousal. So there are direct and indirect mechanisms of slow deep breathing reducing, and then instruction can be used to potentiate that and direct that toward, for example, in mindfulness, to non-judgmentally paying attention non-judgmentally, or paying attention to pain but changing the sensation from pain to something else. That's a technique used in hypnosis, like changing pain to tingling, or changing the size of the pain. So instead of ignoring that sensation, you pay attention to the sensation and try to change it. Well, that may not work for any situation, of course, but that's some variation in the technique.
Yeah, that's what I like about your study with the breathing aspect, because I think people are focused on pain, and many people with pain don't want to focus on their body because they see their body as a place that's unsafe. However, bringing them to the breath or an awareness of the breath introduces them to potentially a bodily sensation that they can begin to approach and they have some control over. And they realize when they approach it in a way that's, for example, non-judgmentally, and they start to regulate their own breathing and they find that it has an impact on their pain, let's say, or maybe their emotion regulation, then they have a bit of empowerment that they experience. And then they feel like, okay, I can do something for myself. I can do something to impact this pain. What are the questions that remain unanswered in this area with regard to breathing? Because if you ask any yogi, they would say, oh yeah, deep breathing is a panacea for almost everything, especially chronic pain. But there are a lot of questions we don't know on a mechanism level and on an investigative level.
I think a bit summary on evidence. Of course, I'm not on top of the evidence, so I may miss some recent, any day you search, there is a new study going on. But I think I saw a recent systematic review and meta-analysis on the influence of slow deep breathing on acute pain. And there is some low certainty evidence in terms of evidence rating that slow deep breathing can reduce acute procedural pain, like in burn, for example. And that's also what we saw in experimental studies, that acute pain, slow deep breathing can reduce it. And we think it's mostly distraction and cognitive. So a combination of expectations, in a clinical situation, you can imagine a clinician or a nurse or a practitioner standing behind or sitting next to the patient. So there is that relationship and communication as well. So expectation, distraction, and a bit of emotion. Not that much of an autonomic modulation, I would say. What happens for chronic pain? There is not that much of evidence. And actually, the evidence shows that, some studies shows that there is no effect, but one or two studies, that's not enough to investigate. So we need more studies in chronic pain, definitely. But the slow deep breathing is combined together with other interventions, like in the context of a yoga, in the context of a mindfulness meditation or HRV biofeedback. There are lots of studies out there. Whether the effect is due to a slow deep breathing, or how much of the effect is due to a slow deep breathing, or whether you take out the slow deep breathing, how much of the effect. These are interesting questions that I think should be answered if we are interested in mechanism. And I think if we understand the mechanism, we can enhance it. We can find for what percent this technique may work and what. I had one participant in one experiment, very interesting. Instead of doing slow deep breathing, the participant was doing mental imagery. And after each test, I interviewed with my participants qualitatively. What was your experience? What did you do? And the participant used mental imagery, and it was much more effective than a slow deep breathing. So this is not something that, as you said, it's not a panacea. It's not going to work for everyone. It can bring some unwanted effects, like, for example, hyperventilation, which can be reduced by using good instructions. So no, it's not a panacea. It's not something that can work for everybody or for every condition. And we need to test it in experimental models and in the clinic and find for what condition and for what person it may work, and find those predictors and then use those predictors to use different techniques for different conditions and for different people. If I want to summarize the mechanisms, and I think that's something that I think our experiments helped a lot, because we try to monitor lots of physiological parameters, I can say. We monitor breathing very precisely, and we use beat-to-beat blood pressure measurement to monitor baroreflex activity and heart rate variability. We found, although we saw in all of the studies a typical cardiovascular response to slow deep breathing, it didn't statistically mediate the effect on pain. And I should say that the statistical analysis may not be a proper way of investigating that. Perhaps there are other methods like pharmacological blockade of the autonomic nervous system. So that's why we think it's more distraction and expectation in short term. In long term, maybe autonomic nervous system can be modulated with long-term practice. And actually, in our studies, we found that those who had lower heart rate in baseline and a higher heart rate variability, these are indexes we use for measuring cardiac vagal activity, they had lower pain intensity. So maybe if we practice slow deep breathing for a long term by having some long-term change in autonomic nervous system, we can impact pain through the autonomic nervous system.
Yeah. I mean, your research is great because it really this one in particular goes into all the different mechanisms, which is great. As you mentioned, if we can figure out those mediators, then we can start to, exploit them, so to speak, in clinical practice and use them for different individuals and maybe different phenotypes and populations. Kind of pulling out into like the big area of mind-body medicine, which is really kind of your stomping ground. Looking at the brain and mind-body medicine, where would you like to see the overall research go in the area of mind-body medicine in general? Because mind-body medicine still is looked at as like a complementary, alternative, integrative method. And many people feel like, well, there's enough there now that this really should be mainstream and it should be part of, the zeitgeist of what's happening in healthcare and especially pain care.
That's a very good question. And I should say I'm a very beginner in the field. It's a very big field, and I think it's going to a good. It's having a good direction. Like if you see what's happening in interoception research, and how interoception influence cognition, emotion, and how that can be used to enhance therapeutic techniques, like for example, desensitization for phobia. There are some trials using the stimuli, adjusting the time of the stimuli based on the cardiac cycle, because it is shown that if you see a visual stimuli emotionally relevant, if you show it during the systole, the response is different when you show it during systole. Diastole and systole is different. So, and there are some studies on using vagal nerve stimulation adjusted based on the respiratory cycle. So using as we understand the connection between brain and body, well, I don't say necessarily we have to have brain and body things, so we need a connection. But let's say, okay, we have a brain, we have a body, if they are separate, which they are not. But anyway, there is this brain-body connection, and there is this dialogue between them both ways. As we understand the physiology and mechanisms, we can harness these information, use them in enhancing the therapeutic technique. So, and these are already being used. I think, like for example, in the whole 4 years of my PhD was focused on this slow deep breathing technique. And we had this question, can a slow deep breathing reduce pain? And we had actually this as a title in one of our papers, and a reviewer said, of course it can. Why you put it in the title of your paper? And we thought, oh no, we don't know yet. There's not consistent evidence out there. So I think we need to, when we want to scientifically test something, we need to test it. We need to consider our assumptions as assumptions and bring it in the laboratory or in a clinical field and test it and interpret it in an unbiased way and report it in an unbiased way. And there is also some problems there, like a publication bias, for example, which we see more of a positive results than a negative results. And I experienced it very much because many of my studies were kind of negative results. So we need to test them more carefully. And I think we are doing that.
Yeah, I appreciate that, because I've spoken to many professionals who say, well, the first place you should start with every chronic pain patient is diaphragmatic breathing. And I think your research, as you mentioned, points to the fact that, well, it might have an impact on some people and it might not have an impact on some people. So let's do a little bit more investigation to find out who it can help. And then we apply that, and that becomes efficient clinical practice, versus who it cannot help. And then we can use other methods to help them. Ali, it's been great speaking with you about breathing and pain, a very niche topic that I really appreciate, because I know it's used a lot in physical therapy and psychology and other mind-body approaches. Tell our listeners and viewers how they can learn more about you and follow your work.
So currently I'm focused on using digital health technology for people with chronic pain, and trying to use it for supporting them. And actually, I try to use these breathing intervention in our intervention as much as is relevant and scientifically sound, of course. So that's my current focus. And if you want to see my work in this area, you can, of course, follow my Twitter, which is at Gholamrezaei, or I'm also on ResearchGate. You can, if you have any question about slow deep breathing, you can always email me or send me a message on Twitter or on ResearchGate. I'm very active in ResearchGate. I'd like to contribute to the discussions about the psychophysiology of respiration and slow deep breathing. So yeah, feel free to contact me any method.
Great. I want to thank Ali for joining us. All the links he mentioned, you can find on the show notes at the Integrative Pain Science Institute, to his Twitter and his ResearchGate. And we may even include his email in there, so you can reach out to him. I'm Dr. Joe Tatta. It's been great joining you this week. Make sure to tune in next week, and we'll see you then. Take care.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.